So on this session in the heart, we're going to be looking at the cardiac cycle. So we're going to be thinking specifically about what's happening to the pressure changes and the volume changes on the left side of the heart. So we're thinking about the left side of the heart, but the same thing will be happening on the right side of the heart. It'll just be with lower pressures and with lower volumes. So at the end of the session, you should be able to describe the timing of the events that are occurring during the cardiac cycle. So when is filling occurring of the atria and the ventricles? And when is contraction? So when are we losing that blood volume into the aorta, for example, or when is it being passed from the atria into the ventricles? So you need to look at the timing of the events that are occurring, but actually what the events of the cardiac cycle themselves are as well. So of course the cardiac cycle describes the events that occur during one beat of the heart, and the whole cycle is initiated by the spontaneous generation of an action potential in the SA node, the sinoatrial node. And as we already know, at the beginning of the cycle, which is towards the end of ventricular diastole, so towards the end of when the ventricles are filling, the whole heart is relaxed. And so are the valves open or closed at this point? So I want you to thinking about the tricuspid and the mitral valves first of all. So we've got our tricuspid between our right atria and our right ventricle, and we've got our mitral valve between the left atria and the left ventricle. So of course, if that's to be open, you would expect the pressure in the left atria to be greater than that of the left ventricle, because they are opening in this direction. They're one-way flow, obviously. So do you think the tricuspid and the mitral are open or closed? Well, they're both open. So the atrioventricular valves, so like I said, that's the mitral and the tricuspid. The atrioventricular valves are open because the atrial pressure is greater than the ventricular pressure, and therefore blood is moving into the ventricles. We're in ventricular diastole, which is ventricular filling. What about the aortic and the pulmonary valves? Well, they are both closed, and that's because the pulmonary and the aortic pressures are greater than that of the ventricles, so therefore they're keeping those valves shut. So there are a variety of different phases to go through with the cardiac cycle, and so we're going to start with the first one, which is atrial contraction. So remember, during most of diastole, so that's filling of the left ventricle, which is shown here, you can see the right atria filling the blood into the right ventricle, same thing with the left atria into the left ventricle, and you can also see the blood returning to the right atria from the inferior and the superior vena cava, and also from the pulmonary vein. So you can see those going into the left and right atria. And so throughout most of diastole, the blood is passively flowing from the left atria and right atria into the left ventricle and right ventricle. And this is your ventricle filling. But during atrial contractions, this is your phase one. This is when you get your ECG changes initially. So you're getting your depolarization of the sinoatrial node. And so towards the end of diastole, both the atria contract. And this propels an additional amount, somewhere between 10 and 20% of blood into the ventricles. And this is initiated by the P wave on an ECG. So this is just shown in this ECG. So you can see your P wave, you then see your QRS complex, and you see your T wave. And this is representing that electrical depolarization of the atria, initiated by the sinoatrial node, of course. And so when we're looking at what's happening, you're seeing the blood is flowing through the atrioventricular valves at this point that are separating the atria and from the ventricles. Remembering, of course, at this point that the AV nodes are both open, which is allowing that blood to flow in. The atrial depolarization, as we talked about, initiates contraction of the atrial muscle, and as the atria contract, the pressure within the atria increases. And that forces more blood flow across those atria, open atrioventricular valves, leading to a rapid flow of blood into the ventricles. That's that final flow that you get, that final 10 to 20% of blood flow into the ventricles. Blood doesn't flow back into the vena cava because of the inertia effects of the venous return. So the venous return coming from the inferior and superior venous cava and from the lungs, of course, pulmonary circulation. And you've got that inertia forcing it all through all of the time, and that inertia stops that backflow. The atrial contraction, as we've talked about, it accounts for roughly 10 to 20% of left ventricular filling when someone is at rest, because most ventricular filling is occurring prior to atrial contraction, because the blood is flowing passively from the pulmonary veins into the left atria and then into the left ventricle through the open mitral valve. But at high heart rates, when there is less time for that passive ventricular filling, the atrial contraction can actually make up a much greater proportion of ventricular filling, up to about 40%. And this is sometimes referred to as, and you might read about it, as the atrial kick. So this is this first phase, the atrial filling, the atrial contraction. So remember, the atria relax. At this point, the atria will now start to relax, and the atrial pressure begins to fall, causing a gradient reversal across those atrioventricular valves. The tricuspid and mitral valves float upwards, and they subsequently go on to close. And the ventricular volumes are now maximum, and that is your end diastolic volume, because you're at the end of diastole. And the end diastolic volume is about 120 mils. So that means at the end of left ventricular filling, there's about 120 mils of blood within the left ventricle. The end diastolic pressure is about 8 to 12 millimeters of mercury, and the end diastolic pressure in the right ventricle is about 3 to 6 millimeters of mercury. But the one we're focusing on, of course, is the left ventricle. So it's about 10 millimeters of mercury. So now we're going to take a little look at the pressure volume diagram of the left side of the heart. And we've only looked at phase 1. Okay, so I'm just going to run through, just look at this little phase 1 initially. These are the sounds that you might hear. So S1 and S2 are the closing of the various valves. S3 and S4 are less common. This is your ECG, so this is the P wave we've just talked about. Okay, this is your left ventricular volume, and that goes, as we've just talked about, up to a maximum at about 120 mils. And then you've got your pressure. And so here you've got in the red, so you can see this little red going around here. This is your left ventricular pressure, so the pressure within the left ventricle itself. This black one down at the bottom, that is the left atrial pressure. And then you've got the aortic pressure up at the top. And hopefully a lot of you will already know that when the heart is pumping during systole, so the left ventricle is pumping, your blood pressure goes up to 120 millimeters of mercury, and that's reflected there in this image on the aortic pressure, and it goes down to 80, so 120 over 80 during diastole, so down at this point. So you can see that's your 120 over 80 that you might have all known about. So we're going to be going through this diagram at each of these different phases. So you've got to remember, as the pressure in the ventricles is less than in the arteries, the semilunar valves, that's the aortic and the pulmonary valves, also remain closed and no blood enters or leaves the ventricles. The left ventricular end diastolic volume, which is this bit here, which is typically about 120 mils that we've talked about, also represents the ventricular preload, and it's associated with an end diastolic pressure of about 8 to 12 millimeters of mercury, as we've just talked about. So now we're going to really look through and go quite slowly through this image the first time, this figure. So here we've got the ECG, we've got our P wave, okay, and that shows depolarization or atrial depolarization, and that will lead to contraction of the atria. And so then if we look at the atrial pressure, that contraction leads to, this is LAP, left atrial pressure. You can see that that leads to an increase in the left atrial pressure, which allows blood to move from the higher pressure within the left atria into the lower pressure chamber of the left ventricle, which is just below it. And so that's shown in red there. And you then see that the left atrial pressure then starts to decrease as, of course, the blood is being pumped into the left ventricle. So the pressure in there starts to decrease. The left ventricular pressure goes up to about 8 to 12 millimeters. So again, that's looking at, there you go, at point A on the image there, which is very slightly than the left atrial pressure. Like I've said, that allows that blood to flow. If you then look at the left ventricular volume, again, that contraction is causing that final 10 to 20% increase. So at this point, the left atria is contracted and causes that last little surge of blood to get into the left ventricle to increase that left ventricular end diastolic volume up to about 120 mils. The aortic pressure, remember that's normally at 120 over 80, at this point is gradually reducing still down to that 80 millimeters of mercury, because we're during ventricular diastole. So this is shown up at the top, so the green part is diastole, the ventricle is relaxing, in other words it isn't pumping, so it's filling. So therefore it's not pumping anything out into the aorta, so therefore the pressure within the aorta is dropping down a little bit. We do sometimes hear a heart sound, so that's the S4 during atrial contraction, and that sound is caused by vibration of the ventricular wall during atrial contraction. But generally it's noted when the ventricular compliance is reduced. In other words, compliance just means the ability of something to stretch. So the ability of the ventricle to stretch has been reduced, and that might be because of diseased ventricles, so ventricular hypertrophy, for example, that occurs in many people with cardiovascular disease and in many older individuals as well. But it's not one of the normal lub-dub sounds that we would be thinking about. So what I want you to do is really press pause and make sure you understand everything that is going on in there. Understand that at the moment we're in left ventricular diastole, so the ventricle is relaxed, the aortic pressure is dropping. We get a little kick in the aortic pressure as it contracts and forces blood into the left ventricle, which causes its pressure to go up a little bit. And that forces the left ventricular end diastolic volume to also go up, and it's also where we saw the P wave, which is the depolarization of the atria, leading to its contraction. So after phase 1, we move into phase 2. So you're looking in the image, you're looking at the number 2. And this is where you get what's called isovolumetric contraction. And this phase appears with the appearance of the QRS complex on an ECG. So here's your QRS complex on your ECG. And that represents ventricular depolarization, which means very soon afterwards, you're going to get ventricular contraction. And that's why we're in the systole phase, in the ventricular contraction phase. So this depolarization triggers excitation contraction coupling, leads to myocyte, which is your cardiac muscle contraction, and a rapid increase in your intraventricular pressure. So remember, your ventricle is now contraction, and you see a massive increase in this left ventricular pressure, because as it's squeezing, it's contracting, and at this point, of course, at the early points, the valves haven't opened up, so we aren't actually squeezing any blood out. So, but as we start, and as that pressure is increasing, it actually pushes the cusps of the AV valves up, and the AV orifices are now closed. So if we're looking at this, the pressure in the left ventricle increases. It's not big enough to squeeze blood out into the aorta and the pulmonary artery, but it's now a greater pressure than that of the atria, so it closes those valves, the tricuspid and the mitral valves. And the closure of the AV valves results in the first heart sound, which is S1 on the image. So again, we're going to take a good look at this, at the figure again, and we're in phase 2. So looking at the ECG, you can see the appearance of the QRS complex, and that represents ventricular depolarization, which obviously, as we talked about, will lead to ventricular myocyte contraction. We're now in the ventricular systole phase, the pumping, the contraction phase. You can see that at point C, the contraction of the left ventricular muscle is leading to a rapid increase in that left ventricular pressure, much greater than that of the atria, which is why, of course, the atrioventricular valves have shut. Because remember that contraction is causing the capacity within the left ventricle to reduce, but the volume of blood has actually remained the same because the valves are all closed, hence why we're getting that pressure increase. Now look at the left ventricular end diastolic volume, and you can see, this relates to this exactly. This remains at 120 mils during this phase. So no blood has been pumped out of the left ventricle into the aorta at this stage. And that, of course, is because the pressure in the ventricles is less than in the large arteries. And again, you can see this up at this point in phase 2. You can see that the left ventricular pressure is less than that of the aorta in this stage, in this phase 2. So therefore, no blood is able to enter the left ventricle or leave the left ventricle at the same time. And that's why contraction is therefore said to be isovolumetric at this point, because there's no change into the volume in the ventricles despite contraction occurring and the pressure increasing. But what you can see as well in this is you can see that the aortic pressure drops a little. There you go. The aortic pressure has dropped a little bit towards the end of the phase 1, and then in the beginning of the phase 2 at that point C, you can see that it's increasing just a little bit. That slight increase in pressure is thought to be due to the bulging of the mitral valve leaflets back into the left atria. And finally, as we've mentioned, you can have a look at the sounds, and you can see the S1, and this is due to the closure of the AV valves, and is the first sound heard in a healthy heart, and that's that lub sound. Okay, so we've now done phase 1, and we've done phase 2, so try and make sure you understand what's going on in each of those phases, because they're quite complex. We're now moving on to phase 3, and we're still in ventricular systole, and this is now called the rapid ejection phase. So during this phase, the ventricles contract further, and the ventricular pressure now exceeds that of the arteries. You can see this in the image, looking at the red up at the top here in phase 3. The left ventricular pressure is now greater than that of the aortic pressure. So the left ventricular pressure has risen up to 120 millimeters of mercury, and that causes opening of the aortic valves. The aortic valve has now opened, which is going to allow blood to pass into the aorta. And likewise on the right side, of course, the pulmonary valve has now opened as well. So the left atrial pressure, if you're looking at this point as well, initially decreases as the atrial base is pulled downwards, which expands the atrial chamber, before then increasing as you're getting blood flowing into the left atria and the right atria, of course, from the pulmonary circulation and from the inferior and superior vena cava, respectively. So just to put it into context, the left ventricular pressure rises up to 120 millimeters of mercury. The right ventricular pressure rises up to 25 millimeters of mercury or so. And that's what causes the opening of the pulmonary valves at that point. Of course, there are no heart sounds that are usually heard during the ejection phase because the opening of healthy valves is silent. There may, of course, be the presence of sounds, for example, systolic murmurs if someone has valve diseases. So if we're looking at the cardiac cycle again, we're seeing at this point in phase 3, there aren't really any changes to the ECG at the moment. We're getting a rapid increase in our left ventricular pressure, which now exceeds that of the aortic pressure, and therefore blood can now leave the left ventricle into the aorta because the valves are now open. And you can see that because the left ventricular volume is now decreasing at this phase as it's being pumped out of the left ventricle and into the aorta. So that's phase 3. We're now moving on to phase 4, and this is called reduced ejection phase. And this is where the force of contraction of the ventricles becomes weaker than the force of contraction during the maximum ejection phase, and that kind of makes sense. But really what's happening at this phase is we're getting ventricular repolarization. And ventricular repolarizations means that there is now less ventricular muscle contraction, and therefore the ventricular pressure begins to drop. And you can see this here. We're getting repolarization of the muscle, and therefore there's less of muscle contraction. So we're starting to get less pressure buildup. But at this point, the valves are still open, and they're still open because the outward flow is occurring due to the kinetic energy of the blood flowing from the ventricles. So that inertia effect again, the energy flowing, the kinetic energy of the blood flowing from the ventricles into the aorta and the pulmonary artery. This is despite the pressure in the ventricles dropping below that of the aorta. And because of that, you can also see that the left ventricular volume that continues to drop down, albeit now at a slower rate, of course, it's the inertia effect. You can still see that the left atrial pressure is still gradually rising, and again, that's because of the continued venous returns from the lungs. And of course, there are no heart sounds that are being heard at this point either. So we've kind of gone through the image, but what's actually happening? So about 200 milliseconds after this QRS complex and the beginning of ventricular depolarization, we then get ventricular repolarization, and that is the T wave on the ECG. And the repolarization is just leading to relaxation of the ventricular muscle. So, and that's what's leading to a decline in the ventricular active tension and muscle contraction, and therefore a decrease in that pressure generation. And that's why that rate of ejection, so the rate of ventricular emptying, falls, though we are having that inertia effect and still getting some blood leaving the left ventricle. So at this point, are the aortic and pulmonary valves still open? Yes, of course, the valves are still open. We're still getting that outward flow occurring from the left ventricle and from the right ventricle, of course, because of that inertia effect, that kinetic effect of blood flow and just forcing it through even though there's a pressure difference. So we're now into phase 5, and we're now, if we're looking up at the top into phase 5, we're now into ventricular diastole. So we now know that the ventricles are completely relaxed and we're going to start to fill up with blood. So during the first phase of this is isovolumetric relaxation. So from its very name, you know that the volume in the ventricle isn't going to change and that the ventricle is relaxed. So during this isovolumetric relaxation phase, the ventricle volumes do not decrease despite a drop in ventricular pressure. So you can see this massive drop in ventricular pressure. So we're getting increased relaxation of the heart, the left ventricle, and a drop in left ventricular pressure. The aortic and pulmonary valves now abruptly close, and that, of course, is because the left ventricular pressure is much less than that of the aortic pressure or of the pulmonary artery as well, if we're thinking about the right side. And the closing of those valves, if we're looking down at the image again, leads to the second heart sound. That's your S2 sound or the dub sound. But valve closure is associated with a small backflow of blood into the ventricles. And this small backflow is associated with a characteristic notch in the aortic and pulmonary artery tracings. So if we're looking at the aorta and pulmonary, or the aorta in this case, you can see this little V shape. That's your little notch. Okay, and that V shape or that notch is due to the pressure dropping more than expected due to that brief backflow from the aorta and into the left ventricle before it kind of recovers itself, if you like. At this point as well, the ventricular pressures are decreasing, remember, but the volumes don't. So now we know all the valves are closed. So the mitral and the tricuspid and the pulmonary and the aortic valves are all closed because the left ventricle is relaxing, but blood isn't going anywhere. So the pressure is going down, but the blood volume is staying the same as shown by the left ventricular volume graph. And that, of course, is the reason it's called isovolumetric relaxation. Relaxation of the left ventricle, no change in blood volume. So at the end of this phase, so this is at the end, this is your left ventricular end systolic volume, and that is at about 50 mils. So at the end of that contraction, you've got 50 mils in your left ventricle. At its peak, the left ventricular end diastolic volume at the end of filling, you've got 120 mils, and that obviously means that you're pumping out about 70 mils per heartbeat. And we'll go through that in the next slide. Oh, just to note, of course, in this, the left atrial pressure, that is continuing to rise due to venous return from the lungs, and the right atrial pressure, of course, increases because of venous return from the inferior and superior vena cava. So I've already talked about this just a second ago, but so we're still in that phase 5. We're in that isovolumetric relaxation, and as I've just mentioned, the blood volume that remains in a ventricle is the end systolic volume, and in the left ventricle, this is about 50 mils. So how much blood has been pumped out of the left ventricle into the aorta in one heartbeat, in one cycle? Well, it's the end diastolic volume, which is the maximum you've got in there. Take away the left end systolic volume, and that leaves you with about 70 mils. So with every heartbeat at rest, you're pumping out about 70 mils of blood from your left ventricle into your systemic circulation. And that blood that's being pumped out is called your stroke volume, the volume being pumped out with every stroke of the heart. And so therefore, if you know that you're pumping out 70 mils with every heartbeat, and you know what your heart rate is, you know what your cardiac output is, because your cardiac output is the total amount of blood that you pump out of your heart every minute. So it is the stroke volume, which is 70 mils, times your heart rate, whatever that might be. Okay, so you can give yourself a rough calculation of what that is. So we're now moving on to phase 6. We're still in diastole. Okay, so we're still in the filling phase. We're in ventricular relaxation, and we're now going to start filling our left ventricle with some blood. So as the ventricles continue to relax at the end of phase 5, the intraventricular pressures eventually fall below that of the atrial pressures. So if we're looking at this image again, following the left ventricular pressure, you can see it falls. And then as we get into phase 6, the rapid filling phase, you can see that it is now less than the left atrial pressure. So now blood can flow into the ventricles down that pressure gradient. But of course, first of all, this pressure gradient means the valves, the atrioventricular valves, the mitral and the tricuspid, will now rapidly open, and the blood can flow back into the left ventricle and into the right ventricle. And the opening of the mitral valve causes a rapid fall in the left atrial pressure, and that's responds to, if you're looking at V there, as blood enters the left ventricle. So you can see that you've got a nice left atrial pressure going up, then the mitral valve opens, and of course blood flows into the left ventricle, so the pressure within the left atria drops, but it is still above that of the left ventricle. So despite that inflow of blood from the atria, what you can see is that the intraventricular pressure continues to briefly fall. And that's because the ventricles are still undergoing some relaxation. So from their contraction state, they're now under still that final little bit of relaxation occurring. But once the ventricles are completely relaxed, as you can see in this, their pressure, the pressures will slowly rise as they fill up with blood from the atria. And you can see as the pressure is going up very slightly there, you can see the left ventricular volume is increasing very rapidly as the atria is allowing that blood to flow down that pressure gradient into the left ventricle. And as you can also see, there are no changes to the ECGs at this stage. There's no contraction, there's no depolarization or repolarization of anything in a healthy heart. There shouldn't be any normal heart sounds at this point, but again, you'll be able to spot from this. You can see this S3. That S3 can be heard in children and occasionally in adults, but it tends to be pathological when it is heard in adults. The main ones we need to focus on, of course, are S1 and S2, which is closure of the valves. So what we've got in this stage 6, we've got this rapid filling as the atrial pressure is greater than the ventricular, and we're getting ventricular filling. And then we move into the final phase, which is phase 7, and this is where we get reduced filling. And you can see that, again, looking at phase 7, you can see that the rate of filling of the left ventricle is now decreasing, but the pressure in the left ventricle is still going up. So as the ventricles continue to fill with blood and expand, they become less compliant. In other words, they become less ability to stretch outwards and gets bigger. And therefore, as they can't stretch out as much, the intraventricular pressure continues to rise, as we're seeing there. The increase in the intraventricular pressure reduces the pressure gradient across the AV valves, so again, across the atrioventricular valves, so that the rate of filling falls late in diastole, and that's what we're seeing in this left ventricular volume loop. And at this point, the ventricle is about 80 to 90% filled at the end of this diastolic phase. What you can also see in this case is that the aortic, and of course the pulmonary pressure as well, but the aortic pressure continues to fall during this period because blood is leaving the aorta, or is being squeezed due to the elastic recoil of the aorta to continue to propel the blood forwards into the systemic circulation. So therefore that pressure is obviously going to reduce because the amount of blood there is reducing due to that recoil effect. And so that then becomes the end of the cycle. We've now finished the cycle, and then we'd be going back into phase 1, which of course is going to be atrial depolarization and atrial contraction, and a beginning of the entire cardiac cycle again. So we've got a couple of questions for you. I'd like you to just press pause. This is just a, sorry, press pause in a second. So the classic normal heart sounds are lub-dub, as we've talked about a couple of times. So the S1 lub sound is due to what closing of which valves at which stage. And then the second question is we're thinking about the dub sound, and that's due to closing of the aortic and pulmonary valves, but at what stage is that occurring? So press pause. If you can, try not to look back at any diagrams. Try and actually work it out in your head when the lub-dub sounds actually are. It's only one slide back if you do need that help. But if you can, try and work it out. That would probably help you. Okay, so the first question. The S1 lub sound is usually heard during closing of the mitral and tricuspid valves at the beginning of ventricular systole. And the S2 dub sound is normally of the closing of the aortic and pulmonary valves at the beginning of ventricular diastole. So if you're not sure what's going on, just go back one slide and you'll be able to have a little look at the image on the right hand side, and that will help you work out exactly what's going on. The final little thing I'm going to ask you to do is, and you're going to have quite a long pause for this one, is I want you to look, we're going to go through each of the phases of the cardiac cycle that we've just done. So atrial systole, isovolumetric ventricular contraction, etc., etc. And I just want you to tell me at each stage, or each phase rather, are the atrioventricular valves, are they open or closed? Remembering that's your tricuspid and your mitral valves. And what about your semilunar valves at that stage? Are they, so that's your pulmonary and your aortic valves, are they open or closed? And then just crudely, I want to know what's the status of the ventricles and the atria. So are they relaxed and filling? Are they contracting and emptying? What's happening at each stage? And so I'm going to go through this with you, but what I'd like you to do is to press pause, work out the first line, then we'll go through it. And then you press pause again and go through the next one. I want you to be thinking about it at each point, because I'm not going to give long explanations. We're just going to go through it quite quickly. So, press pause, think, because I'm just going to carry on. So, atrial systole. So, during atrial systole, of course, the atria are contracting. So, the atrioventricular nodes, valves rather, they are, of course, open because blood is being pumped from the atria into the ventricles. The semilunar valves, they are closed because the pressure in the ventricles is less than that in the aorta and the pulmonary artery. What about the status of the ventricles and atria? Well, of course, the atria are contracting and emptying because that's what atrial systole is. It's about contraction of the atria. And the ventricles are relaxed and filling. So phase 2, isovolumetric ventricular contraction. So at this phase, both the AV nodes and the semilunar valves are closed. And what's happening at this point? Well, we've got isovolumetric ventricular contraction. So the ventricles, from the very name, are obviously contracting, but there is no volume change. Hence, the semilunar valves are closed and the atrioventricular valves are closed. And the atria are relaxed, because you don't have the atrium ventricles contracting at the same time in health. We now have rapid ventricular ejection. So now we're getting ejection. So now we know, right, what valves are going to be open? Well, clearly the semilunar valves are going to be open because now the pressure in the left ventricle is greater than that of the aorta. So that opens. But it's also the left ventricular pressure is greater than that of the left atria. So that causes the AV nodes to close. The AV nodes are closed, valves, I keep saying nodes, the AV valves are closed and the semilunar valves are open. The ventricles are contracting and emptying, and of course the atria are relaxed and filling with blood returning from the systemic circulation, if it's the right, or if it's the right, or the pulmonary circulation if it's the left. We then have reduced ventricular ejection. So the AV valves, again, they're closed, and the semilunar valves are also open. In this case, the contraction strength is now reducing. So the ventricles are starting to relax. We're getting depolarization of the ventricles, but they're still emptying. There's still blood flowing into the aorta. And again, the atria are relaxed and filling. We now move on to isovolumetric ventricular relaxation. And at this point, the AV valves are closed and the semilunar valves are closed. And you know this because the very name is isovolumetric. There is no change in the volume within the ventricles, and they're relaxed. And if there's no volume in change, the blood can't be going in any direction. So they have to be closed. So the status, ventricles are relaxed, no volume change, atria relaxed and filling. We now have rapid ventricular filling. So during rapid ventricular filling, of course, we now need to have the appropriate valves open. So the AV valves now need to open because the ventricles the blood needs to get in from the atria to the ventricles. So the valves need to be open. So the mitral and tricuspid are. And the semilunar valves are closed, obviously, because the ventricular pressure is low. And at this point, the ventricles are now relaxed and they are filling. And the atria are relaxed and they are emptying. So it's all about pressure changes, pressure gradients there. Now we now go through the reduced ventricular filling stage. And again, the AV valves are open, the semilunar valves are closed, and the ventricles are relaxed and filling, and the atria are relaxed and emptying. And then, of course, the very next phase after this is back up to atrial systole, where the atria contract, and we go through the whole cycle again. Now, hopefully, you've got all of that. And that is the end.